Okay, here we go. This is 2016 ICD-10. We are just going over the guidelines. That's what this video will be. I'm actually starting on page 4 of the guidelines. Starts with the conventions, which we have already gone over, placeholder, seventh character, that kind of thing. There's a couple of abbreviations I did not go over. NEC and NOS. These are pretty self-explanatory. There's different punctuation to look at. I did do the excludes and includes. Some of this, as we use the codes, it's a little bit easier to understand, so I don't just pick it apart here. Good definitions of your excludes in 1 and 2. Information here about your code first and use additionals. I did go on and highlight my book some. I don't know if you can see it. I used yellow. Maybe I should have used something else. A few definitions of when you see and, what that means, when you see with, what that means. Then we're getting into the general coding guidelines, and that's really what I want to touch on today. Number 4, signs and symptoms. That's where we're going to start. So if you have signs and symptoms and you have the definitive diagnosis, example being patient presents with a cough and congestion, the doctor ends up diagnosing that patient with upper respiratory infection. You would not code the signs and symptoms because they are inherent or integral to that definitive diagnosis of upper respiratory infection. So this is telling you that if you do have a definitive diagnosis, then you code the definitive diagnosis and not any of the symptoms. If you have symptoms that are not explained by a definitive diagnosis, then you pick up those symptoms. Conditions integral to part of the disease process. That's kind of what I just touched on. Here's some more on code first and code if applicable to kind of give you, I'm afraid I'm going to have some throat issues. Code first is always going to give you your sequencing issue. So code first means that's the first code, and then code everything else after it. I always get lots and lots and lots of questions regarding sequencing of the diagnosis codes. If you have a question, the guidelines are where you go. 9 times out of 10, you can figure out your sequencing by coming here to the guidelines and then getting in the right area, I promise. Acute and chronic conditions. If you have on the same date of service acute and chronic conditions, acute will always be sequenced first. So let's say you have acute kidney failure and chronic kidney failure. You're going to code the acute first and then code the chronic. The combination code up here is pretty much telling you if you have acute and chronics and there's a combination code, you always defer to the combination code. You wouldn't separate them. If you can find a code that has both things in it, then code that one code. Sequela is your late effects. So a patient had a stroke 2 years ago and now has hemiparesis on her right side. That hemiparesis is a late effect or a sequela of the stroke she had 2 years ago. Stroke is not the issue now. Her mobility probably what that hemiparesis is, or hemiplegia. Impending or threatened conditions. There are some diagnosis codes. Threatened abortion. Which is like a miscarriage happening. Impending MI. Those kinds of codes you can actually code because there would be a code for them. Most of the time, impending or threatened pneumonia, impending pneumonia. That doesn't give us pneumonia. There's no way to crosswalk that in this book. So you would just have to code the symptoms, cough, congestion, whatever. But if you can actually find under impending or threatened the right lingo for what you're looking for, then you're allowed to code them. Pretty much the outpatient rule is, it has to be definitive. Probable, suspect, maybe, likely, maybe. Those are not definite affirmations or confirmations of diagnosis codes, so we cannot code them. If a doctor says probable pneumonia for that outpatient, based on the outpatient rule, probable pneumonia is not a code for us because it's not telling us that they definitively have pneumonia. So we would have to default to the signs and symptoms for that date of service. BMIs, body mass index, cannot be coded as a first code. It always has to be second. So say your documentation, the doctor says that your patient is morbidly obese and their BMI is a 43. So you would code the morbid obesity and then you would code the BMI of 43. You cannot put that BMI in front of the morbid obesity. Okay, now let's get into our chapter specific. What I mean by chapters is the tabular section. Let me get there. I have so many colors here. The tabular section of the ICD-9 is made up of chapters. And the first chapter, it says chapter 1. Whoops. Chapter 1. And so every time you get into a different organ system or disease process, that chapter will change. It'll go to chapter 2, chapter 3, on and on. And you can see all along here the chapters. You see on the color that the different colors tell you the chapters. That's another way to kind of navigate through. So in the actual guidelines here, we're going to start with chapter 1, infectious and parasitic diseases, and then move forward. I am not going to go over every part of the guidelines. You guys just have to read it. I'm going to kind of hit the highlights. As we work through the different chapters and parts of the tabular, please, please, please come back and review this stuff. I cannot tell you, the more you know these guidelines, the better equipped you are to navigate the diagnosing system and to get the correct codes. Okay, so starting with chapter 1, this is where a lot of different codes are found. One particularly specific area is your HIV and AIDS area. You only code confirmed cases of HIV. Only code confirmed. And then you have some rules over here, this column. If a patient is being admitted for HIV-related conditions, then you're going to sequence the HIV status condition first, which would HIV-related, which would be B20, and then you're going to code specifically what that condition is. So your HIV-related or your AIDS would be sequenced first. A patient being admitted for an unrelated to HIV or AIDS, you sequence that unrelated condition first, and then you follow it up with your AIDS or HIV code. You do not use an asymptomatic. In ICD 10, you have two codes. You have an asymptomatic, just an HIV status. They're HIV positive. No symptoms. They've never had any AIDS-related illnesses, nothing. That's a Z21. For the patient who has ever in their history had an AIDS-related illness, means that they have converted from an asymptomatic HIV positive status to an AIDS-related or HIV-related status. That means they will always be B20 from then on. So there's two codes. Z21 is your HIV positive asymptomatic. B20 is your HIV-related AIDS illness or AIDS. And that's what this is telling you. Do not code from an asymptomatic if there's the word AIDS in the chart, or if the patient has ever been treated for an AIDS-related illness in their past medical history. They have converted from an asymptomatic status, and they are considered a B20, which is a HIV-related illness or AIDS. I think that's probably good on that. There are more in here specific to pregnancy, specific to previously diagnosed HIV, that kind of thing. But I'm not going to read you everything. Just know, what I want you to walk away from this video knowing, number one, that these guidelines exist and they are absolutely the Bible to this manual. If you do not understand them and use them accordingly, you won't use your codes correct. And know that how it's divided. Be familiar enough that if all of a sudden you're coding an AIDS-related or a neoplasm cancer chart or something, then you're like, you know what, I better come and read my guidelines. I'm not sure that I remember what to do. And your guidelines, 9 times out of 10, will get you the information you need that you can apply it to your current data service or to that chart. Over here, D, sepsis. Severe sepsis and septic shock. That's what we're going to talk about now. This is, for those of you who know ICD-9, this is how we used to use our SIRS codes, the 99591 and 92. This kind of navigates us through that. Those SIRS codes are now the R65.2 series or around there. So this is just telling us when to use the severe sepsis and when not to. The organ failure has to be documented as linked to the sepsis. You can't just, oh, they have congestive heart failure, so let's link it. You can't do that. It has to be associated with the sepsis. Your severe sepsis, you're going to have a minimum of 2 codes. One being your sepsis, and then one being that R65.2 severe sepsis, and then you may have to have another code to tell which organ system has failed. If you have lingo like septic shock, that in its essence gives you, it represents a type of acute organ failure or dysfunction, so you can automatically use out of that R65 series, 65.2 series, and then it gives you some direction on how to sequence your severe sepsis. This is good stuff in here. Also gives you some indication on how to sequence a post-procedural infection with sepsis, localized sepsis, that type of thing. Over here is sepsis related to a non-infection process. And then let's move to our MRSA. So don't get confused. We have MRSA, MRSA, methicillin-resistant Staphylococcus aureus. We also have MSSA, methicillin-susceptible. So we have resistant and susceptible Staphylococcus aureus. So as you're reading these codes, don't get confused. Make sure in your mind you know you're talking about MRSA and not something else. This area kind of helps you figure out how you do your combining of meds and your of diagnosis codes and your sequencing, how to use your MRSA codes with other codes, carrier codes for MRSA. I actually see that sadly quite a bit in my ER charts. Moving into chapter 2 is our neoplasm codes. Definitions of primary malignant neoplasms, overlapping sites, malignant neoplasms of ectopic tissue, kind of definitions for those. Then there's all different ways of how to sequence your neoplasms depending on what the scenario is. It isn't always cut and dried that neoplasm goes first. So if your treatment, this is on A, if your treatment is directed toward the malignancy, then that malignancy is going to be either your first listed if it's an outpatient chart or principal diagnosis if it's an inpatient chart. It's a little bit of lingo you need to kind of understand. When you see principal diagnosis, most likely that's going to be an inpatient chart. When you see first listed diagnosis, that's probably an outpatient chart. Your older docs don't understand that lingo or haven't changed with the times, but that's typically how it would be. B, treatment of a secondary site. So you have a primary cancer and a secondary site. So the treatment is only going toward that secondary site, so it's going to be sequenced first, even though you know there's a primary. It's getting the attention for that date of service, so it gets sequenced first. If you are being admitted for anemia because of your malignancy, the treatment is only for the malignancy, then the malignancy is sequenced as the first listed, and then you code the anemia appropriate. And you would probably pick the anemia to the neoplastic disease if that's what the documentation is. Probably it is. Number 2, anemia associated with chemo. So if the patient has an encounter for management of anemia associated with an adverse effect of the chemo or radiology, chemo or immunotherapy, and the only treatment is for the anemia, then the anemia is sequenced first. The adverse effect is next. Okay? This is when you really get into these scenarios, this is going to be helpful for you to know that this information is in here and it's laid out. Same thing for malignant or management of dehydration due to malignancy, primary malignancy previously excised. If it's not having any treatment and they say that it doesn't need any further treatment, then that's going to be a personal history code. Administration solely for chemo or radiation or immunotherapy, you're going to sequence that Z code first. It will be the first code. And then the malignancy, what the chemotherapy is treating, whatever cancer it's treating, will be listed as a secondary code. Very important sequencing there. You see that quite a bit. Admission for pain control. This kind of H will cover that in a different section. Sequencing of neoplasm codes. Your treatment of the primary is sequenced first, obviously followed by any metastatic sites. Treatment of a secondary malignancy, that metastatic site that is being treated would be listed first, and then the primary would be listed second. It all depends on the picture painted on that date of service. If that date of service they're addressing one certain thing, then that's what you have to take into account when you're determining your sequencing. Okay, then current malignancy versus a personal history. That gives you a little bit of a definition. Your leukemias, multiple myelomas, and your malignant plasma cell neoplasms that can go into remission. Sometimes it's confusing on, do we put this as a personal history now or do we put it as in remission? This will kind of help you figure out how to target that. We don't have too many, if any, guidelines for Chapter 3, so we'll move on to Chapter 4. This is the endocrine. Most of our diabetes and that kind of endocrinology or nutritional metabolic type of issue is going to be in this chapter. It obviously starts out with diabetes, tells you the type of diabetes. If the doctor is talking about diabetes and does not give you a type 1 or type 2, you default to type 2. That's what this tells you. So type 2 is always the default. Also with a type 2, if the patient is receiving insulin, you will code also for the long-term use of insulin, which is Z79.4. That's here. Type 1 is insulin dependent, so you would never code insulin also with a type 1. It's only with a type 2 diabetes that is insulin dependent that we code also that insulin. As a way of definition, your secondary diabetes are always going to be caused by something else. So you specifically have to have the documentation from the doctor. Patient has secondary diabetes because of he lost his pancreas 2 years ago, whatever. Or patient has secondary diabetes due to long-term steroid use, whatever it is. That way you know that their diabetes is caused by something else. It's a secondary effect. And that's what this area goes over. Chapter 5, we finally have a little bit of guideline for our mental behavioral disorders. We haven't had much, if any, guidelines ever. So it's kind of nice to have a little bit. Overwhelmingly, kind of what you can come away with for this is, number 1, some of the mental health codes have an in remission status, so look for that in your documentation. And we've long time had issues with the lingo of patient uses, patient abuses, and patient is dependent. So here is pretty much the definition of. So if in your documentation you have use and abuse, then you're going to code to the abuse. If you have abuse and dependence, you're going to code to the dependence. If you have all 3, use, abuse, and dependence, you're going to code to the dependence. So we finally have a little bit of a concrete guideline. And use is just use. If they're not telling you that it's abused or they're dependent, you can't make it that way. So you would only code to use. We kind of go round and round with tobacco, smoking with that context. Okay, chapter 6, nervous system. We finally do have a definitive that if the patient is right-handed, they are considered to be dominant on the right side, even if they don't tell you. So the right side, if the right side's affected, the default will be dominant, left side would be non-dominant. Finally, we have something written that our right side can now be our dominant. Here's our G89. This is our pain control or pain area. Your G89 should not be assigned if the underlying diagnosis is known. You're also going to have, they're specifically down here telling you how you can use G89 series of codes as a principal diagnosis. There aren't too awful many ways that you can, but this is typically for pain, general pain. It would be better if you had more detail, acute or chronic pain or neoplasm-related pain, if you had specifics. But if all you have is just pain, you're kind of stuck with that, and that doesn't crosswalk to very specific codes. Your chapter 7 is the eye and adnexa. A little bit of information regarding glaucoma. In this H40 series, you could stack those codes, use as many as were applicable to your scenario. Make sure that you understand if there's a right and a left of something, a body part, there's probably going to be a right and a left code, except for breast, which is strange. There'll be a right and a left code, so make sure that you're picking the left or the right or bilateral. Getting into chapter 9. This is a heavily used section, especially in our HCC coding areas. So, if you have hypertension with heart disease, this particular area, you cannot code hypertensive heart disease to a patient unless the doctor links or corresponds the hypertension to the heart disease. So here the examples tell you that they may say patient has heart disease due to hypertension, that just linked it. Or the doctor may actually just say hypertensive heart disease in the assessment and plan. That would link it as well. But you cannot assume a relationship between hypertension and heart disease. That is different than your hypertension with your CKD. So really take your notes here. This is what really can kind of mess folks up. Hypertension and CKD, chronic kidney disease, you can presume as the coder a cause and effect relationship. So if you have hypertension and if you have CKD, any stage or end-stage renal, on the same date of service, you do not have to have the doctor link those for you. You can link them, and then you're going to have to use your hypertension out of the I-12 series and not the I-10, and then you would sequence the CKD or end-stage renal after the hypertension. Okay? So your hypertensive heart, the doctor has to link them for you. Your hypertension and your CKD, they do not. There's an implied relationship that you as the coder can code accordingly. And then the third area is when a patient has hypertensive heart and CKD. If the doctor has documented hypertensive heart and the patient has a chronic kidney disease or end-stage renal, you can code appropriately and combine all of those instances into this one area. And then it tells you how to code that. Your coronary artery disease for ICD-10 is defined either with angina or without. Your with angina is the I-22.11, your without's the I-25.10. Make sure that you're picking the correct code with that. Just know that that's a little different than previously. If you don't know previously, then it doesn't matter. A little bit on your sequencing of acute MIs. We have some other MI stuff on this next page, so I'm just going to kind of scoot over here. Sorry, I have to move the book around like that. Okay, so sequela of the cerebrovascular accident. This is the hemiparesis. Remember a little bit ago I had a patient 2 years ago had a stroke, and now they have hemiparesis on the right side. That would be a sequela or sequelae or late effect of that stroke. And this is where you would get those codes from. It was on the right side. You would assume the right side is the dominant. So you would pick your codes accordingly. Acute MIs in ICD-9 was up to 8 weeks. In 10, in the ICD-10 world, is only 4 weeks. You can have STEMIs or non-STEMIs. You can have non-STEMIs that evolve into STEMIs, vice versa. So read this very carefully. Your old MIs, it doesn't say in here, but anyone that knows ICD-10 and knew it as 412, it's now I-25.2.2. Your acute MI is unspecified. That's if you don't know where in the heart or what type of heart attack it was. You would just use an unspecified. ICD-10 also allows you, if a patient has a heart attack and within that 4-week period that heart attack is still acute, has another heart attack, then category I-22 would be used. This would be having a second heart attack or subsequent heart attack in the same 4-week period that you're healing from another one. Very different than ICD-9 world. Chapter 10, these are respiratory. Talks about acute respiratory failure. Remember, if you have acute and chronic conditions, acutes are always going to be sequenced first. I'm not going to go over a lot of this. There's just different sequencing, what to do with influenza, ventilation dependence, what do you do, ventilator-associated pneumonias, that kind of thing. Then we're into, oops, nabbit, sorry about that, I'm probably making you sick. Chapter 12 is your skin and sub-Q. Talks about your pressure ulcers. These are in section L89 of your tabular. You can use as many codes out of the L89 section as you need to in order to get all of your pressure ulcers, if you happen to have a lot. Unstageable pressure ulcers, what do you do with that? Documented pressure ulcer stages. The stages code, what do you do if they document it as healed? How do you code it? You don't, because it's healed, so it's not there anymore. Documented as healing. Just some good basic information in here. Chapter 13, bone versus joint. This is musculoskeletal section. In here, you're going to have fractures, pathological fractures. You're going to really use your 7th digit a lot in the musculoskeletal section. This section of the ICD-10 probably increased by the most codes of anywhere. Orthopedists, I'm sure, are going crazy all over the nation. You have osteoporosis. You have osteoporosis without a pathological fracture, osteoporosis with a pathological fracture, and kind of how to assimilate to the correct code. Chapter 14, genitourinary. This is your CKD, which is an N18 series, N18. Remember, if you have a CKD with hypertension, your hypertension will sequence first, and then you'll sequence your CKD. You'll need to track any transplant statuses. Moving into chapter 15, this is pregnancy and childbirth. Your pregnancy codes now have a final character for the trimester, first, second, or third trimester. You also have a 7th character for a fetus, whether it's a single gestation. You use a 0 character if it's a single gestation, because 1 means there's more than one fetus. When the documentation in the record is sufficient to determine the fetus is affected, it's not possible. You don't have clear clarification, or when clinically it's not possible to determine which fetus is affected. But most people have one baby at a time, and so the 7th character in here would be a 0 for that single gestation. Different sequencing of what is first listed for pregnancy. Your Z34 series is the encounter for supervision of a normal pregnancy. O09 is your first listed for supervision of a high-risk pregnancy. Episodes when no delivery occurs. What do you do when a delivery does occur? Your outcome of delivery is a Z37 that can only go on the maternal chart. All of these codes in here can only go on the maternal chart. It tells us that over here. Let me fold that. See right here, chapter 15 codes used only on maternal charts, so none of these can go on the baby's chart. And then there's just a slew of particular scenarios. So when we get into our maternity coding, this will probably be a place you come back to. Normal delivery in the old world, ICD-9 was 650, I think. Normal delivery here is 080. And then you have your outcome, which is the Z37.0 or whatever your fourth digit is. Not too much has changed. I will say that in pregnancy now, there are Z codes, and we'll see them in a minute when I get back to that section. But for every single time a pregnant person encounters healthcare, the weeks of gestation has to be tracked on the chart. Every single time. That's brand new this year. And I'll show you those Z codes in a minute. Chapter 16, these are conditions originating in the perinatal. So these are actually fetus issues. Something's happened, and these codes can actually, chapter 16, can follow that fetus into infancy, into childhood, into adulthood, if the condition is still present. Okay? And that's what this tells you right here. Chapter 15 codes are never on chapter 16 codes, because chapter 15 is the mother, chapter 16 is the baby, and you cannot mix their records. Chapter 17 are congenital malformations. And then that's kind of it for the more specific body areas or organ systems. Now we're kind of into generic stuff. So chapter 18 starts with signs and symptoms and abnormal conditions or clinical findings and that kind of stuff. Kind of generic stuff that probably aren't the best codes to use, but can be used until there's a more definitive diagnosis to be found. And we've already kind of talked about how and when to use symptoms. If there's a definitive diagnosis, you're just not going to. One code that we had in ICD-9, but it was hardly ever used, was a history of falling code. With our increasing elderly population, this is very much a code that is being tracked and watched now in our quality reports. So I just kind of bring that up. That's just one of my things. Also death, this R99, this is not death, not otherwise specified, is not any kind of discharge diagnosis. That's just an event that happened. You would still have to have an actual diagnosis code to show why somebody died. Chapter 19, this is your injury and poisoning. This has your 7th characters, A for the initial, D for a subsequent, and then S for sequela. I do want to make mention, there's an area right here and it's bolded in your manual. While the patient may be seen by a new or different provider over the course of treatment for an injury. So the patient is injured and they see Joe Blow, and then they change doctors and see Joe Smith, and then they see Joe Pettigrew. The assignment of the 7th character follows the actual injury. It does not follow a new doctor seeing the patient for the first time. So once the patient has had an initial encounter for that injury, they can't have another initial encounter for that injury. Even though they may have a new doctor that's seen it for the first time, and it's the doctor's initial time to see the injury, it is not the injury's first time. So make sure that your 7th characters track the actual injury and not the doctor, the new doctor. And that's what that's telling you. It gets very, very confusing for folks, I promise. Here's a good guideline on your fractures. A fracture not indicated as open or closed is coded to closed. So if they said patient has a fracture of the right fibula, you assume it's a closed fracture. A fracture not indicated whether displaced or not displaced should be coded to displaced. So that is key to picking the right code. Key. Moving into burns, pretty much The biggest piece of information or guideline from burns, and this has not changed from ICD-9, you always code to the highest degree. So if on my forearm I have a 1st-degree burn, a 2nd-degree burn, and a 3rd-degree burn, for whatever reason, say I have that, you're only going to code to the 3rd degree. The 1st degree, 2nd degree are included in the 3rd degree. You had to go through a 1st and a 2nd degree to get to a 3rd degree. So you're always on the same body part, you're always going to code to the highest specificity or the highest level of burn, and then drop the other two. That's per body part. Adverse poisoning, effects poisoning, that table that we looked at on the last video. This gives a pretty good kind of definition of what adverse means, of what poisoning means, underdosing. It does caution you to never code directly from the table of drugs. ICD-9, a few times you could just code from it. ICD-10 you can't, because most of the codes are going to require more digits to them. So you have to go and verify them in the tabular. You have to. Here's some definition of the adverse effects. Different definitions for your poisoning. Your underdosing kind of gives you the scenario like underdosing. Taking less of the medication than is prescribed. Then there's just some kind of status codes. Transplant complications, you're going to always want to have a status code about a transplant. Kidney transplant complications, you're going to need to have that status of the transplant. And then we're going to get into our, holy cow, I am so sorry about that. I wish my camera was better. Our general external cause coding guidelines. And this is the section that I refused to go over the last time, but I'm going to go over it now. If you have experience in ICD-9, these are like our E-codes that we used to have, but they're not E-codes anymore. It's completely different. The definition of general external cause codes is down here on number 3. And it says they describe the cause, the intent, the place of occurrence, and the activity of the patient when they were injured. So if something externally caused injury to the patient, that could be the patient falling, that could be a car hitting them, that could be a motor vehicle accident, that could be a roof falling on them, it could be glass, being shattered and it ended up cutting them. Whatever externally caused their illness or injury, you have to have these external cause codes to accompany your real codes. And then it kind of goes and explains all those different areas that I just went through. The place of occurrence, the activity that they were doing, the cause. None of these codes can ever be listed as a first listed. You would always list what that injury is. These are supplementary codes describing or painting a picture of what actually made that patient injured or ill. Typically, most of these codes are just going to be tracked the first time. The first time the patient seeks treatment for whatever that illness slash injury was, that something externally made them sick, that's when most of these codes will be used. Now, let's break from this and let's go to our external cause index. It's on page 695, external cause index. This is what I skipped in the last video. And this is the actual index for finding the external cause codes. In ICD-9, we had the same kind of index. The codes just look different. So here, this is where you're going to find the different accidents, the different activities, the place of occurrence. Let me just randomly go to a page. Oh, it's still an accident. There's your activity. Your burns are here, bitten by an animal, just about any kind of animal you could come up with. This is when you see on Facebook and they say, oh, there's a code for that. This is probably where they're getting it from, something like really crazy, traveling on a train and bitten by an alligator or something. You can probably get that combination in here. Just really, it's probably where all that funny stuff comes from. It is kind of funny. There's terrorist stuff, drowning stuff, explosions, just everything. Just take a little bit of time and look through here. Falling, getting struck by something, forces of nature, like a tornado from where I'm from Oklahoma, so we get lots of tornadoes. But that's the index that you would use in order to find your external cause codes. Okay? Now we're back to we're almost done. We're back to our guidelines. I'm on page 33. Chapter 21, this is the last chapter of the ICD-10. For those of you who have ICD-9 experience, these are what would have been our V codes. These are now Z codes. V codes in ICD-9 were supplemental codes. These are not. These are full-fledged codes that we have to use, and there are a slew of them. So just to kind of get you familiar, these Z codes are pretty much anything that influences your health status. Maybe you have a pacemaker. Maybe you only have one leg. That obviously affects your health care. Maybe you are encountering health care just to get your contraceptive surveillance. Maybe you have an IUD, so you need to have it checked. That would be a Z code. Maybe you're showing up for your yearly preventive examination. That's a Z code. You are taking your kids in to get their yearly or every other year vaccinations. That's a Z code. So pretty much nothing in the Z's are you acutely sick. These are all kind of statuses or stuff that helps paint a more clear picture of your healthcare status. So let's look at the different areas. And I am by no means going over all these. There's way too many. But there's your vaccination codes. So anyone who knew ICD-9, we had a V code for every single kind of shot you could get. Not in ICD-10. It's Z23 for all of them. That's two things in ICD-10 that's easier for us. That's one of them. Status codes, anywhere from a genetic carrier to a blood type to long-term drug use to absence of limbs, just your status of something. Maybe you've had a bypass and you have grafts. Maybe you have a pacemaker. It's a status. It would be in here. Your history ofs. Is it a history of your personal history or a family history? Could be either. So there's all kinds of personal and family. There's screenings. Maybe you're having a breast cancer screening, prostate cancer screening, colon cancer screening, antenatal screening for pregnant women. All kinds of screenings that you could do. Different observations of stuff. Medical observation, because they're going to watch you. Maybe you were exposed to TB, so they're going to watch you to see if you contract it. Aftercare. Aftercare would imply that you have seen the doctor before for a problem, and now they're providing you with some aftercare. So here are some examples of it. Maybe you had artificial opening, maybe in your colon, a coloscopy. No, I didn't say that right. Yeah, colostomy. Yeah. Sorry. That's one of those like brain things. I think I combined colonoscopy and colostomy. That's silly. Okay, anyway, don't worry about me. So you're having attention to that artificial opening. Orthopedic aftercare. Maybe you've lost a limb and you need to be, you're being watched or fitted for some kind of prosthetic device. Just all kinds of stuff. Follow-up. Maybe you had surgery and now you're being follow-up or having a follow-up. Maybe you've been treated for cancer and you're having different appointments and now you're going to have a follow-up. Maybe you're a donor. Counseling. You got to quit smoking. You got to lose weight. You want to have a baby. There's a slew of counseling. Reproductive kinds of things. Here's your contraceptive management, supervision of normal pregnancy, all of that. You see there's just a slew of these suckers. Newborns and infants, routine administrative examinations. There's 1,000,001 of those. Organ removals, prophylactic organ removals. Prophylactic would imply maybe you have the BRCA gene. So, or the patient, not you. The patient has the BRCA gene, so they are prophylactically going to have a double mastectomy. And that's kind of it. There's a couple of more pages I want to go over, but I do want to show you in your book. There are two places, and I'm not crazy about your book because it has all that ICD-9 stuff in it too, which just drives me nutso. But in your book, there are two places that have a list of kind of trigger words that would help you find these Z codes or these health status codes in the index. Okay, so kind of look at that. This is after, I can't give you my page number because I have a different book, of course. I don't know, it's before the ICD-9 E codes. So look for that, and that's good lingo for your 10 too. And then this one, this is in chapter, that was in chapter 2, and I think this is chapter 4, but this is the same kind of list to help you find those Z codes. Okay, now remember, to find your Z codes, you go to the actual index, regular index. To find your external cause codes, you have to go to the external cause index. So don't get them confused. You'll be looking all day. You'll still be looking there, and we'll move on to another chapter. Okay, there's a few pages left in here that have a little bit of information regarding selecting your principal diagnosis or a first listed diagnosis. Kind of reviews some of the stuff that we've already gone over, but it's a little bit of guideline information. Might be okay for you to go over it now. Some of it may be a real review, but when you get to page 44, this present on admission reporting, this is strictly for inpatient, so don't worry about it. You will not be tested on POAs on the board. We, on an outpatient basis, we do not track present on admission diagnoses, nor do we worry about the exempt list for the POAs. So just don't even worry about this information here at the back. It's of no use to you on an outpatient physician-based reporting status, so don't even worry about it. Okay, so hopefully you have enough to at least get you going, hopefully. So I guess do the best you can, and then on our Thursday conference calls, we'll hash out whatever the questions are. You guys are doing great.